Welcome to Team 7's presentation of South Korea's healthcare system, a study in creating stakeholder value. South Korea has grown rapidly over the last half-century, with a per capita GDP of $133 in 1966, ballooning to over $27,000 in 2016, prompting observers to dub the growth the miracle on the Han River. This same miracle enabled the government to transition from an out-of-pocket healthcare system based on preventative and curative traditional medicines to an increasingly regulated and centralized one that merged both Eastern and Western medical traditions. The government's role in the healthcare system began to formalize in 1963 through the passage of the Medical Insurance Law, which allowed individuals to sign up for voluntary health insurance. Progressive expansions enabled the government to attain universal health insurance coverage in 1999 when it implemented the Unified Health Insurance Act. Today, South Korea's healthcare system is considered a variant of the national health insurance model patterned on Canada's and Japan's. It is characterized by a single-payer approach, government financing of its insurance system through contributions, general taxation, co-payments, and value-added tax on tobacco products, near-universal coverage but unequal access, patient autonomy in choosing their general practitioner, a cost-containing two-tier system of GPs as gatekeepers to specialists, and the dominance of privately owned and managed hospitals, clinics, dental facilities, and oriental medicine facilities. South Korea ranks at the bottom of OECD countries in practicing physicians and practicing nurses. The health system enjoys adequate levels of satisfaction for its medical services, with public health centers getting the highest marks. Stakeholders interact to convert available human, financial, regulatory, and societal resources into outcomes of interest. Key stakeholders and interests include the national government, which promotes population health and financial sustainability, the National Health Insurance Corporation, which guards financial sustainability more narrowly. Providers seek to protect their autonomy and secure a good return on their educational investment. Regulators want increased clout and often conflict with pharmaceutical companies that fight to maintain the current system of low regulation surrounding drug prescriptions. The citizenry is an expectant stakeholder that is dependent on definitive stakeholders to turn their legitimacy and urgency into outcomes through the addition of power. The government has been successful in improving population health. Life expectancy has risen by close to 3 decades. Communicable diseases are down, as are infant mortality rates. It has historically been an efficient provider of services, attaining adequate population health at reasonable per capita costs. Still, South Korea's health system is not without problems. A chronic issue has been inequity in access, with financial incentives resulting in excessive services in urban areas at the expense of rural ones. However, the major issue is financial sustainability. South Korea has the highest rate of growth in health spending in the OECD from 2005 to 2015, 6.8%, which is 3 times higher than the OECD average. What are the fundamental causes? We've identified 7 key internal drivers of financial unsustainability. One is a weak two-tier system, with GP gatekeepers unable to limit access to second-tier specialists, usually a key cost-saving device of such models. The problem relates to the fact that 80% of doctors in South Korea are medical specialists, creating a clear conflict of interest that weakens the gate between the tiers. A second factor is the country's rapid adoption of new medical technology, which, though generally justifiable to bring medical breakthroughs to those in need, nevertheless tends to increase system costs. This is reinforced by the over-specialization just mentioned. A third factor is the high level of spending on pharmaceuticals, consuming 20.6% of total health costs, compared to an OECD average of 16.3%. A fourth factor is disproportionate autonomy granted to medical professionals, leading to excessive overuse of antibiotics, more MRI machines per million population than anywhere else in the world, and cesarean delivery rates of about 40% of live births, again related to overspecialization and a weak two-tier system. A fifth factor is the expansion of the benefits covered under national insurance, often obtained through popular pressure and itself an indication of deficiencies in the decision-making process. This is an example of the dynamism of stakeholder relations. A normally demanding stakeholder, that is, the general citizenry, can become, in a given context and with the right allies, a definitive stakeholder able to effect change. A sixth factor threatening financial stability is that, because the fee-for-service system is closely regulated, providers compete for more patients on quality as opposed to price and encourage more frequent office visits, hospital admissions, and more intense service provision. We emphasize here that a definitive stakeholder who effects change as desired, in this case the regulator, may nevertheless cause unintended, often counterproductive systems level effects through its action. The last internal driver of financial unsustainability is the average length of hospital stays in the country, 16.5 days compared to an OECD average of just 8.1 days. The key external drivers of financial unsustainability is a marked shift in demographics. Low birth rates and increasing longevity result in an increasingly elderly population, which is associated with a lower labor force participation rate, leading to lower system revenues and to higher per capita medical costs for longer periods of time. Lower revenues and increased costs translate to financial stress for South Korea's healthcare system. This driver is only expected to exacerbate the internal drivers of financial unsustainability outlined previously. An important assumption underlying our discussion of financial unsustainability, its contributing factors, and the criteria on which we base our action plan is that contributing factors would have continued to interact in a similar fashion to how they have in the last decade, with similar consequences. In short, we extrapolate from healthcare trends, demographic trends, and fiscal trends what would have happened in the short term and the long term in the absence of the action plan. Because the extrapolated trends portend an untenable system of care given desired service levels, the action plan is designed to improve on this counterfactual. We expect a looming crisis, and the South Korean government would do well to respond vigorously.
In order to address challenges unique to the South Korean health system, we've identified outcomes-based criteria for selecting recommendations. In order to formulate an action plan for the South Korean health system, we've identified 3 stakeholder-focused and systems-based criteria. Each criterion reflects measurable outcomes and reflects how the system's strengths can be utilized to improve upon current and anticipated weaknesses and challenges. They also capitalize on synergies between systems components. The triple aim of healthcare outlines 3 goals that result from improved systems functioning and implementation of long-term sustainable approaches. The 3 measures of the triple aim will serve as our criteria. They are improved patient experience as measured by patient satisfaction according to the Korean Primary Care Assessment Tool and public health outcomes, improved population health in terms of population disease burden, and lastly, reduce costs in terms of outcome to cost ratio, increased efficiency of care, out-of-pocket costs borne by patients, total healthcare expenditures including hospitalization and specialist share of cost. As mentioned in the description section, the South Korean healthcare system faces several interrelated challenges involving different stakeholders. Our action plan determines short and long-term action items and goals. Each action item addresses a challenge faced by the Korean health system. Through the interaction of all action items, we devise a systems approach for improving healthcare delivery and sustainability. Our action plan steps are as follows. Public health centers scored highest among care providers in terms of health outcomes and patient satisfaction. By expanding public health facilities in rural areas, underserved populations will receive preventive care, reducing inequity. Expansion of public health care will also help to reduce Korea's lengthy, costly hospital stays. Successful population health begins with improving access and incentivizing patients to engage in better self-care. In this way, population health results from the combined efforts of patient stakeholders and primary and public health care providers. Initiatives will include health cooperatives that focus on 3 kinds of community participation, such as medical, health services, and community development. Elderly populations will also benefit from increased access to quality care via public health deployments. A stronger public health sector will help combine the rising dependency ratio due to the graying population and the shrinking tax base. Improving patient satisfaction in public health facilities will include these initiatives. Efforts should be made to reduce the patient load at higher level facilities so that doctors and other staff can give more attention and time to the patients. Efforts are also needed to strengthen infrastructure and human resources at the lower level health facilities. This bears a close relation to the issue of inequity in access in rural versus urban areas. Although citizens were able to expand benefits in the national insurance system, access and inequity issues remain. Rural patients need advocacy from healthcare providers in order to become definitive stakeholders, able to influence their own health outcomes by demanding increased access to equitable care. The government, as a definitive stakeholder, will need to make healthcare access and equity paramount goals. Improving access and equity will translate to better health outcomes and less expensive costs of care in the long term. This is increasingly important as the population continues to gray, aging out of the tax base, and burdening the healthcare system with more expensive care. The disproportionate autonomy of physicians within the Korean health system has bred overspecialization and overutilization, including long hospital stays. In order to expand primary care and reduce utilization of hospital and specialist resources, the OECD recommends increasing DRG-based payments, using selective contracting with providers based on performance, and lastly, utilizing bundled payments that prospectively combine payments for hospital admission as well as a reasonable number of pre- and post-admission services. These measures would reform the weak 2-tier gatekeeping system and would reduce oversaturation of specialists and thereby reduce costs of care. The current system of incentives leads to competition on quality, which drives up costs. Instead of measuring on quality alone, outcomes should be measured as health outcomes achieved per dollar spent. This method, combined with reducing specialist oversaturation, will help limit overspending, such as investing in new technologies, overprescription, expansion of benefits, and also overutilization and excessive treatments, such as long hospital stays and quality-driven competitive practices. The Korean citizenry, acting as a definitive stakeholder, was able to advocate for ever-expanding benefits under the national security system. Now, outcome-to-cost measures need to be applied to make sure care delivery actually benefits as many stakeholders as possible. In order to measure the success of the health system in meeting the Triple Aim criteria via the action plan, we will use a monitoring plan. The Korean Primary Care Assessment Tool will measure patient satisfaction in primary care settings. Similar methodologies will be applied to patient satisfaction with public health access, equity, and quality of care. We will also monitor patient satisfaction with regards to availability and cost of pharmaceuticals. The government will need to be careful not to shift too much of the cost of pharmaceuticals or care improvements onto patients. Public health will be quantified by measuring the disease burden of the South Korean population. Disease burden measures the prevalence of disease and disability-adjusted life years. Sources of information on disease burden include utilization reports, past patient data, the Korea Central Cancer Registry, and the Korea Centers for Disease Control and Prevention. Data will need to be updated each year so that patterns, progress, and new challenges can be identified in order to guide future health policy interventions, and research. The World Health Organization's macroeconomic model assesses health systems' inputs, outputs, efficiency, and outcomes. According to the World Health Organization, the South Korean health system benefits from increased efficiency of care delivery with increased healthcare spending per capita up to a certain point. It is this point of efficiency that the South Korean government needs to aim for, the point at which inputs of marginal cost are offset by increases in marginal efficiency or benefits in delivery of care. This will include assessments of new technology, implementation, and pharmaceuticals. The cost-to-outcomes ratio will also be applied in determining whether implementation of new technologies, pharmaceutical interventions, or expanded benefits are beneficial. In addition, the World Health Organization posits that health systems have the ability to increase efficiency without increasing spending, and that due to restrictions by possible biological limits on healthy lifespan, overall efficiency is more a representative measure of the true efficiency of health systems than one based on health status alone. Indeed, South Korea must assess outcomes, processes, and the interaction of the two. Lastly, as South Korea expands its population initiatives, it needs to balance upfront investments in infrastructure changes with better population health, patient satisfaction, and reduced costs in the long term. Out-of-pocket costs borne by patients and increased expenditures of hospitals and specialists will be indicators of an inefficiently functioning delivery system. As an important part of the monitoring plan, interactions between stakeholders and systems components must be continually reevaluated. This is a critical step in fine-tuning the action plan in order to achieve the intended outcome criteria. In the development and implementation phase of this plan, many of these synergies and potential pitfalls have not yet become apparent. However, to consider at this point are potential adverse effects of curbing pharmaceutical spending, including patient access to medication, upfront spending costs of public health initiatives that might be met with resistance from stakeholders such as government. Quality of care at public health facilities will need to be closely measured. Patient and physician resistance to benefit cuts needs to be monitored. Growing elderly population may continue to increase the cost of care delivery, which may shield the effects of action plan from outcomes. And lastly, medical innovation could suffer due to lack of funding for new technologies. South Korea faces unprecedented growth in healthcare expenditures. Only determined governmental action in close collaboration with the right stakeholders will ensure a sustainable system of care that meets the expectations of the South Korean people. For South Korea, action must start today. Thank you for joining us for this presentation.